Good afternoon, everyone, and thank you for joining us. My name is Sebastian Probst. I'm a professor of tissue viability and wound care at the University of Applied Sciences and Arts in Western Switzerland and the University Hospital of Geneva. And I'm the current president-elect of the European Wound Management Association. Together with Luc Théo, head of Department of Plastic Surgery, Burns and Wound Healing, Montpellier University Hospital, and the current EWMA scientific recorder, I will be moderator of this webinar. This webinar is the 5th webinar in a series of webinars focusing on the various aspects of the implementation of telemedicine in wound management. This time we will focus on telemedicine in Denmark, where efforts have been made over the last 10 years to achieve a nationwide telemedicine program in wound management. The webinar will be recorded, so you will also be able to watch the webinar on demand. The recording will be available via the EWMA website within a few days. You will be able to request a certificate of attendance for the live participation in the webinar if you participate in minimum 70% of the live webinar. A link to the certificate will be sent after the webinar. The 3 speakers of each talk will speak about 15 minutes. After this, we will have some time for some questions and a discussion. Please note, if you type your question in the Q&A box anytime during the webinar, if all questions cannot be answered in the webinar, they may be addressed in future webinars or the EWMA communication channels. I am now pleased to introduce the presentations and welcome the speakers in today's webinar. Our speakers in this webinar are presented here on the screen, and this is Britta Raven. She is a head of the Telemedicine Center of Central Denmark region. Klaus Kirketreb-Møller, he is at the Gisberg Hospital and Steno Diabetes Center in Denmark, and Trine Røllinger Thomsen, Associate Professor of the Danish Technological Institute in Aalborg University. And now I would like to hand over to the first speaker, Britta Raven, who will talk about the Danish model organization of telemedicine in Denmark. Please, Britta.
Thank you so much, Sebastian. I'm pleased to be here today, and thank you for having me for this presentation. I'll now share my screen with you. Today I'm here representing the Central Denmark region, where we work with telemedicine for all the hospitals in the region, but I'm also representing the steering committee of wound management, and it's a national steering committee, and I'll tell you a bit more about it later on. The topics I will touch on in this presentation is a little bit about the Danish model. How did we get started and how is it organized today? And also, what have we learned during these 6 years where we have had this solution implemented in all the country? And finally, I will touch a bit about the challenges and also successes that we have seen following the implementation of the telemedical wound assessment. The reason that we started with a national solution on telemedicine was a joint national strategy from 2013 to 17, where there were focus areas such as moving away from paper journals, connected care and cross-sectoral cooperation and better use of data was very important for us to reach. Also patient empowerment, how to make it possible for patients to have treatment at home, and establishing transparency on moving towards large-scale projects. We had a history in Denmark of having a lot of telemedical projects, but only at local level. And we wanted to have a possibility to have large-scale projects in the whole country. And one of the first topics we touched upon was dissemination of telemedical assessments of ulcers as one of 5 national initiatives. And maybe I should say that I will use the word ulcers and wound not as terms for what we're talking about today, knowing that it includes different kinds of wounds. The dissemination of wound management in Denmark is spread out in 5 regions with the responsibility for the treatment at hospitals, and 98 municipalities who have the responsibility for treatment of patients in the homes, and often wounds that are not very complex. When it's so complicated wounds that we need to have physicians at the hospital and specialists to be part of the treatment, then the patient will be referred to the hospital. Also, we have approximately 3,400 GPs in Denmark who also take care of wounds in different ways. The way it's organized in Denmark is that we have a national board of health IT at the top level who are responsible for all national solutions. And then we have under that a steering committee of joint IT solutions in the health sectors, which consist of representatives from municipalities, from regions, from the general practitioners, and from the national boards of IT. Under this, we have different steering committees, and the one I'm talking about today is the steering committee for telemedical wound management. Some of the other things we have is the shared medical journal we have in Denmark and other committees. So we have, I think it's about 10 or steering committees solutions that we have joint steering committees between municipalities and hospitals in Denmark. Under our steering committee, we have a joint system management and we have a joint user group. And then we have the 5 regions where we have the region in Central Denmark region, for example. We have the region, and then we have 19 municipalities. And we have our own user group, and we make our own agreements on how to cooperate about the wound management in this area. And likewise, they do in the other regions and the municipalities in these regions. How does it work today? Patients, community nurses, and nurse specialists at the hospitals use mobiles or iPads to take photographs and describe wounds, and then they share it on a common platform that we have bought all together. So the 103 identities, the 5 regions, and the 98 municipalities have bought this solution in common. And the patients and healthcare staff in all sectors can assess the solution and see, the patient can see their own pictures and the notes on it. And we can share notes between hospital and community nurses. The solution is used cross-sectoral for complicated wounds and monosectoral for wounds where cross-sectoral cooperation is not needed. And I will be back to that in the end of the presentation. Patients can either be treated in their home, at a health center in the municipality, or at the GP or at the hospital, where they go to be seen when they have to be seen by physically. In Central Denmark region, we have 5 hospitals, that is the red circles, and we have 19 municipalities. We have approximately 850 GPs and 1.3 million citizens. The green circles is the municipalities that cooperate in clusters with the hospitals. So they have a close cooperation between the nurses and the physicians in the hospital and the nurses in the municipalities who also are taking care of the wound management. So what have we learned after these 6 years? We have learned that communication is very, very important. It's important to know that that when we send a message or leave a note in the system, that it is responded upon in the other end. It's also very important to be able to talk about things that we are uncertain about. And it's very important in the communication that we have what's it called, structured way for communication, for writing notes about wounds, and we use a structured way called time. It's put into the system where the nurses will write about the wound according to the areas, or what's it called, in the time way of describing the wound. Another thing that we have learned is that working together cross-sectoral gives a competency boost for all parts who works with wound management. So both the nurses at the hospital, as the nurses in the municipalities, at the GPs, and the patients themselves feel that they have more knowledge about how to manage wounds, and it's easier for them to get support and advice from a more knowledgeable person. Also, it's very important to have a cooperative agreement where it's stated how we organize the wound management between municipalities, hospitals, patients, and GPs. One of the things we have been working with in Denmark when we implemented this common solution was we had a joint what's it called, description of what is needed of competences at different levels. For example, we have physicians working with wound management where we said experience within wound management, acquiring knowledge about wound management through courses and clinical supervised training, keeping up to date with national clinical guidelines, and experienced user of the telemedical platform. Often in the daily work with the telemedical platform, it's the nurses who are taking care of the photos and the descriptions, and who talk with the patients and set up the assessment of the wound. And then they have the physician in the background, so to speak. So if there are problems or difficulties or things they are uncertain about, they can talk with the physician about that. The next level in the competency is the nursing specialist in wound management at hospitals and also in municipalities, where we have said that a diploma degree in wound management is preferable to have at least 2 years of experience. They should be super users of the telemedical platform, and in the municipalities, it has been said that we should have at least one nursing specialist in wound management per 15,000 citizens in the municipalities. The RN providing wound care in municipalities have a 5-day seminar in wound management and experienced use of the telemedical platform. And then they use the nursing specialists as consultants in their daily work. Also in Denmark, we have nursing assistants in municipalities who work with wound management. And normally, at the beginning, we said that it was only nurses and trained RN nurses who should take care of the treatment of wounds. However, the reality is that in a lot of municipalities, due to lack of nurses, the daily treatment of wound will be done by nursing assistants. So we have focused on e-learn, focusing on prevention, but also in Central Denmark region, we have made a 5-day seminar for nursing assistants to be able to cope with wound management. And the nurses working at GPs were also, we have some recommendations for having a diploma degree and at least 2 years of experience, and also knowing the telemedical platform. So that's something about the competences that we have set together, agreed upon in Denmark before implementing the telemedical solution. Some of the challenges we have met is that it has been very difficult to involve GPs in the joint solution. And one of the reasons for that is that it has been a standalone solution that's not integrated to their daily electrical journal. And it takes time for them to go into the solution when they have a patient with a wound. And they have double registration and they don't have the time for it because it's difficult for them. And it's difficult for them to gain sufficient experience in using the platform, as they do not have that many patients in each practice with wounds. One of the successes we have seen is that some of the patients they go from, here we have set a passenger to an active co-pilot, and it's because Ole, as you see here, he's a bus driver, and he had serious ulcers, diabetic foot ulcers, for more years, and he was about to lose his job because of he had been sick in a long time, and he had been 6 months at home. Having the access to the telemedical solution helped him because he could follow how the progress in the healing of his ulcer, and also he was able to see that when he stopped smoking and got more active and had kept his diabetic diet, he could see that his ulcer was healing faster. It helped him to be proactive, to seek advice from the nurses that was engaged in his treatment. And also he was able to go seeing his daughter who had moved to Canada, and he wouldn't have gone there. He received treatment from home, from the nurse telling him what to do and how to change his plaster when he was away in Canada for a month. So he felt empowered and he kept his job. So that was a success. And more patients have said the same, but one of the challenges we have with the solution we have today is that it's not that patient friendly. It's not user friendly for patients. It's a bit difficult to learn. So I think what Trine will tell you more about is we're trying to make another solution which are more patient friendly, so to speak. Another success we have seen is one of the municipalities. They have inhabitants, about 300,000 inhabitants in this municipality, and they have worked very seriously with implementing and also in the organization of how to build competences in their among nurses in the community. And we can see here that from March 17 to November 19, and that's the newest data I have, they have had an increase in community nurses using the solution. In the beginning, they were organized so that it was only the specialized nurses, where there were only 5 who used the platform. But they found out that it was very necessary for the nurses, the community nurses, who went out to patients and saw patients with wounds and were engaged in the wound management and treatment. that they also learn to use the platform, send in photos, and make notes of the wound. So they have now about approximately 80, and they say they need to have more nurses engaged in the working with the platform. They have approximately 200 patients per month, and some of them, you know, are terminized in when they have no more problems, and so it's approximately what they have at all time is 200 patients. And the green line is the cross-sectoral pathway where patients are treated and the plasters or bandages are changed from the community nurses, but the treatment responsibility is at the hospital with the specialists. And there, of the 200 patients they have in the solution, 140 approximately are cross-sectoral pathway nurse patients. Some of the things they have had also with success about is they have an increased number of patients with active plans in Plionet. In the beginning, they were very good to start patients, but then forgot to keep the active plans, put in new photos and updating the notes on the ulcers. And that's because it's a standalone system that are not integrated in their electronic journal. So they have to register two places and document in two systems, and that has been a problem. So therefore, sometimes the activity in the telemedical solution faded out, but they are steady now with that. Also, they have a increased number of community nurses using Plionet, as I told you, and they have had a decrease. You cannot see that on this graph, but they have had a decrease in numbers of treatment of ulcers and use of bandages and plasters with approximately 1/3, from about 9,700 to 9,600 to about 6,300 changes or treatments in the municipality. So it's been a big success where they have seen that putting effort into organization, using this telemedical platform, and be able to get a higher competency level in the municipality has helped them reduce the numbers of visits with patients with ulcers and the amount of money used on plasters and bandages. And they have very satisfied patients in the municipality as well. Thank you.
Thank you very much for your presentation. Please to add any questions you may have to Britta in the question box, and we will address this after the last presentation. We will hand over now to the second speaker, to Klaus Kirchenthaler-Müller, who will talk about the value of the digital tools from the perspective of the healthcare personals. Please, Klaus.
Thank you, Sebastian, and thank you for inviting me to share this presentation with you. And I hope you will stay to the end so you can ask all the questions you need to ask. I'll try to share my screen here. So it's about the needs and challenges in digital wound treatment. And my name is Klaus Kirchenthaler-Müller. I'm a consultant at the Copenhagen Wound Healing Center in Bispebjerg Hospital, and I is also working at the Steno Diabetes Center Copenhagen in Denmark, that is maybe more familiar to you. So there are multiple stakeholders in the treatment of wounds. You can have the multidisciplinary team and wound nurses, tissue viability nurses, all the persons that Britta actually mentioned in the first talk. So there are a lot of people involved in this treatment, and it can be quite challenging to bring the knowledge around. And a very old, in my young days, this paper was actually brought from pregnant women from the GP to the hospital to all the stakeholders in the pregnancy, and they had to keep track of this paper in order to keep the notes. And if they lost it, all the informations were lost. And now we actually have this knowledge carried around in the electronic systems, and less risk of having lost all the knowledge. Nevertheless, it's not optimal to have these records different places. And Britta also mentioned that we had different records in the hospital, at the GPs, now at the telemedicine. They are all different records that are not really speaking together. So it is a challenge to be a stakeholder in one of the teams and then communicate with one in the other team. And sometimes the patient is actually the messenger in this, and that's not optimal. So telemedicine has been around for quite some time and used for heart disease, emergency cardiac medicine, heart failure, pacemaker surveillance, psychiatry, asthma, wound treatment, and they all have chosen different solutions to do that. In the wound, or in most cases, it's about communication with the patient and maybe some monitoring in the home. But in wound care, it's more like a conference with a specialized team, as you see here in the middle, with the nurses and the patient in their home. So it's by proxy that the multidisciplinary team can guide and practice with the nurses in their home. And I know that's different from Denmark to other countries. And I know, for instance, in UK, it is quite common that the patient is in the other end of the computer and is guided by the nurse. But in Denmark, as you have heard here, we have actually chosen a solution where we have a nurse or a nurse assistant out in the home to treat the patients. And the telemedicine purpose could be to increase the competence of the local healthcare provider, as told by Britta. That is the proxy out in the home. And it also have the point that the patients avoid visits to the hospital. It can empower the patient and maybe increase the quality of life for the patient. And it also increases the flexibility in treatment because the patient can be more independent in the how they are seeing the nurses, and maybe even go to a center in the municipality to have their dressing changed. And it may also be value for money in healthcare. As it's by proxy telemedicine, so we do need to have someone out there to change the dressing, because most of our patients are not able to change the bandaging by themselves. So if you add compression, it's difficult, and sometimes the wife or the husband can help, but it is something that requires some knowledge and experience to do that correctly. In Denmark, it's also difficult to get the materials, and they are also expensive. You have to buy them by yourself. And sometimes an on-the-spot assessment is required, because a picture may show you many things, but it can also hide some things like infection, for instance. So we need someone out there. But in wound treatment, we can talk about the 4 pillars of wound treatment. And if you look at the telemedicine, for instance, how can they actually provide all 4 pillars? If you just look at offloading, for instance, they can give advice to the diabetic patient that they should not really walk so much, or they could give advice that they should wear the offloading shoes, but they cannot make adjustments in the shoes. At least I don't think they can. And maybe some other professional could actually help there. The revascularization is not an issue because they cannot do anything there. They may be helpful in the assessment of the vascular system, but it's unreliable. So it have to be done in the hospital in most cases. The infection control is also difficult. They can do local debridement, but the nurses cannot prescribe antibiotics. They can do some antiseptics and use antiseptic dressings, but it's not what the same as they can do in the multidisciplinary teams. So they are restricted somehow in the 4 pillars of the wound treatment. And Dr. David Armstrong have said, for instance, the diabetic foot ulcer heals not because of the things we put in the ulcer, but what we take away. So the offloading is essential in the treatment of diabetic foot, and that have to be taken care of too. So what are we missing actually, or what is something we would like to have in the telemedicine as well? Well, there are some competences and skills that could be needed out there. Podiatrist could be actually a good player in the treatment of diabetic foot ulcers. We need to have some more patient empowerment because they need help in the treatment of the wounds. And we, the prescribers of the treatment, and the patient need feedback, and the patient need nudging in order to do what is actually good for them. Because as you know, the diabetic foot ulcer, for instance, they are not having any benefit here and now from offloading. The only benefit they get is that they heal their ulcers maybe in weeks or months, but they really need nudging in order to do what's necessary to heal their wounds. We need a close monitoring of the ulcers, but that's already done with the nurses and the pictures. But we also would like to have some knowledge about the patient's activity, how they use the shoes, and do they use the shoes or the compression, if they take the compression off in the night and when they do it, and what's actually the reason for that. And we do need some technological integration so that we do not have files that are not able to communicate with each other. So we still have some challenges in the telemedicine project. So this is just a hypothetical wound, or the wound is actually real, but the curve is someone I have just thought of. So basically in the telemedicine, you will have this record of the size of an ulcer. And it seems to go fine in the beginning, but then suddenly it's increase in size, and then it stays there. But what if we actually had the possibility of counting steps at the same time as we measure the ulcers? And this is a hypothetical thing, but it may be that if we could see that there was an increase in the number of steps that is parallel to the size of the wound, then it would be easier to advise the patient that you should not walk as much as you do, and use the shoes. So it could be helpful in the communication with the patient. And we can monitor all sorts of things. The picture on the right is a product made by Cyrene, and it's quite amazing. It's not for advertising for it because it's not available in Europe, but this sock can actually measure temperature, and you could imagine all the things you could put in such a sock. So it can also count the steps you take. It may also be able to tell you whether you use the offloading software. It can maybe also be used to measure the load on the foot. I don't think it can measure blood sugar yet, but I think there's other devices that can do that. How about the sleep? Are you sleeping well, or are you walking the whole night? And of course, it would be nice to have something that monitor wound size, maybe even automatically. And the technological integration could be done with smartphones, smart devices, and maybe the pressure sensors under the foot temperature measurement, and image processing that would be automatic with the wound assessment and wound measurement, and maybe even giving advice to the treatment during the course between the changes of dressing. So that may help the patient actually. But this is, wish thinking. But so this information would go into the wound record, the patient record, the GP and the municipality at the same time, and not only in one of them, and the information is kept there. So we need to have the integrated, and we also need to have some feedback the other way to the patient in order to increase the healing of the wounds. Empowerment can be done by data which supports the decision, provide feedback, giving nudging, and even warning of aggravation. And I'm most familiar with the diabetic foot ulcer, and that's why I talk about that all the time. But if you have a warning on your phone that says now you have actually exceeded the 3,000 steps that you were advised to do, maybe you should not go to the store today to buy a new bed. Maybe you should postpone that until tomorrow. That may be helpful information for the patients that are not aware that their ulcers is getting worse if they walk more than 3,000 steps, for instance. We also need to do more research and data that are shared across platforms and are safe from abuse and filtered may be helpful in the research, which would be covered by Trine in the next presentation. But the information that comes to the providers also need to be filtered. And because if you get too much information, too much data, you get data overload, and then you're not actually able to extract the important things. And maybe this could be targeted and by artificial intelligence in due time, maybe. We also need to be sure that, to acknowledge that the patient doesn't only have a wound. So this is a randomized controlled trial in the southern part of Denmark, and they treated diabetic foot ulcers, then randomized them to either telemedicine support or business as usual in the multidisciplinary team in the university hospital. And quite surprising, there was an increased mortality in the telemedicine group. We don't think that actually it's the telemedicine that's causing the increased mortality. But it may be that we are forgetting that the patient also have diabetes, they have heart disease, they may have all sorts of disease that is not taken care of if they are not seen at the multidisciplinary team. This is just my explanation. It's not clear actually what's the explanation behind the increased mortality, but we need to keep an eye that the patient is not only a wound. So summing up, wound treatment have multiple providers, long courses, mixed competences in all the providers. We need to have empowerment of the patient, and communication, as Peter said, is very important. And we also need to use the data that we actually do create today. And I know we'll create more data in the future. And we should use it in a flow. So it's not something that comes 6 months later, but it has to be a flow, and we have to use it. And we have to look at new technologies and integrate that in the telemedicine as soon as possible. So we would like to put the patient in the center and advocate for dynamical use of data. And we only present necessary data to the patient and to the healthcare providers. And we would like to integrate data into the treatment of the patient. And that may be something that you can have on your phone, actually, on your own phone, with all the data and all the knowledge that we have to treat the wound. And I know Trine will tell you more about that. So thank you for your attention.
Thank you very much, Klaus, for your presentation. Again, please add any questions you may have in the question box, and we will address this after the presentations. Finally, I would like to hand over to Trine Rølinghed-Thomsen, who will talk about her work to provide new relevant tools and data collection to increase the value of the patient organizations. Please, Trine.
Thank you very much for the invitation. I will talk about the increasing the value for patients and organizations by new tools and data collection. And this is in cooperation with a lot of people and partners you can see below, because this is a part of a large project. It's a research project called Health D360. It's public-private innovation. We are 19 partners. It has been running for 2 years and will end this year. You can see much more details on the website. Some of the information will be in Danish only. The background for this large research project is that we aim to create better health for the citizens by gathering data from health systems, from registers, and link them with patient 24/7 data. And the ambition is to promote more personal, secure, and coherent treatment in close collaboration with the patient's relatives, and healthcare professionals. And the citizens are in the center of all of it, and we start with their perspective. We have 2 applied cases in this project. One is about mental health and obesity in young people, and the second one is about diabetic foot ulcers, which will be in focus today. Time is tissue. We all know that a wound can quite fast result in amputation. It costs a lot of money and affect the patient significantly. We would like to turn those graphs, and the aim and purposes of this project is to understand some of the major potential risk factors and life events being important for the development of diabetic foot ulcers. And we will use a lot of artificial intelligence in this study. And we focus primarily on the diabetic population here in Denmark. Another purpose is to develop tools co-created by the citizens and healthcare professionals to collect and monitor all relevant information on their diabetic foot daily. And we have a lot of focus on the empowerment. And we want to collect various relevant data sources. So, what events are important for the development of ulcers? Risk factors like age, gender, do they have neuropathy, etc.? Or is it other events like social events, divorce, they got a new job, they are retired? Or is it change in behavior like exercise, holiday, etc.? Is it possible to improve treatment, diagnosis, and prevention for the individual citizen? Is a focus area for us. Now I go to the major potential risk factors and life events for developing diabetic foot ulcers. Here in Denmark, we have 3 types of data sources. We have national registers with general population data. We have demographics, comorbidities, etc. The update is low frequent, typically once a year. Then we have local care data from the municipalities. It's wound measurements, it's blood pressure measurements, it can also be visitation times, etc. And it's updated medium frequent. And then we have the personal tracked data, 24/7 data from apps, personal devices, etc. We monitor daily activity, and this has a lot of potential. Right now, I would like to present this article towards machine learning based risk identification in diabetes, which just was published, where we focused a lot on register data, but also some local care data. We had a population cohort on Danish national registers. It was both normal registers, but also medicine registers, with citizens born between 1900 and 1968, and that included 3.5 million citizens. And among this population, there were close to 250,000 patients being diagnosed with diabetes. That could either be by codes or by medicine intake of certain medicine. The highest risk factors for developing diabetic foot ulcers are low family disposable income, cardiovascular disorders, neuropathy, and chronic renal complications. You can look much more in the paper on the details and analysis. It is possible to improve the machine learning results using data from citizens' daily life. These are municipality data on blood sugar measurements. They are in blue, and wound size, that's orange, where we can correlate much more frequent data. And we will look at a lot of data in the next coming month. We have also been doing a lot of co-creation, looking at which concepts are the most urgent ones to look at in this research project. We have brainstormed and discussed and observed with patients, relatives, healthcare providers, and there are so many interesting things to look at, and they're all relevant, I think, and there are a lot of needed concepts. So I think there are still a lot of things to do. But one of the concepts was a wound app for the citizens. They really have asked for a tool to collect and monitor relevant information on their diabetic foot, but on a daily basis, and it should be their own tool, not a healthcare tool. So we said, okay, we go for that. That's what I will present now. We have done a lot of field studies, code design, test of wireframes, and the first version is in Danish only. It's available in App Store and Google Play. And what you can see is here that the user registers a wound, and daily they can report if the wound increases in size or not. They can register pain, inflammation, wound fluids, and the development of the wound is visualized together with other data types. So they say, okay, I have so much pain and so much fluid, etc. Infection, yeah, the size, how deep it is, and how active they have been. And here you can see some visualizations with more parameters. Over the 7 last days, you can see how many steps they have taken and how deep the ulcer is and the size of the ulcer. So all these are a lot of questions, but this is combined with a data plugin collecting activity data from Apple Health Kit and Google Fit. And these data are sent to a research database at present. And I will mention that the app is developed using current standards, FHIR frameworks, and best practice guidelines. Right now, we have flyers, posters, etc. out at the hospitals and also at municipality clinics. And we have focused on recruitment of patients for using the app. So we are collecting data. And who made the app? Yeah, it has been a very interesting, very cross-disciplinary project. The front end has been made in close collaboration between Cambio Systems, Opus Consult, and the Alexandra Institute. And the back end has been made at Alexandra Institute and Danish Technological Institute and Bispebjerg Hospital. They are product owner on this product, and all data analyses are made at Aarhus University. And this project is a research and development project, and it's much research focused, and it's not, the purpose has not been to make a major market ready product, just to be aware of that. In addition, I would like to mention, sorry for this being in Danish, but we have made digital consent to donate data from the municipality. So they can click on this link where you can see here on the left side, and then a citizen can say, I would like to donate my municipality data, and then they can sign up for that. And that's really great that it don't have to be personalized, that you sit in a waiting room and ask a person to join this. I think this is cool, the digital consent. And I would also like to show you Ideate Nu. That's a platform for sharing and discussing concepts and knowledge. And there are more concepts and ideas from patients and healthcare professionals in relation to diabetic wounds, where you can sign in and comment. It's also a lot in Danish at present, but I think it's very nice to have an environment where you can do this discussion and have a lot of interaction on what's the most interesting things and most important things to focus on for the future research and development. What data sources do we have in this project right now? I have mentioned most of it. We have data from the municipalities, visitation times, blood sugar measurements, description of wounds. It's right now necessary to have consent from each citizen to get this. We have register data, normal registers, medicine registers, income, education registers, which are all approved, and we have a closed, secure system and at Statistic Denmark to do all the data analysis. Then we now get more and more data on the 24/7 data with the Wound app. And within maybe 1-2 weeks, we will have data from another large project called Tværsspor, where they have data from laboratories and from medicine registers and also some municipality data. And that will be very cool to combine with all our other data. And then we also have a permission to get access to this Plejenet Britta mentioned, but we still don't have figured out to receive the data. But there are a lot of interesting data around these patients, which are so important for further research. So the next steps are data collection, more data analysis, machine learning, etc. And we really hope to improve both compliance and also knowledge for the citizens and minimize the delays so we can flatten the recurrence curve. Thanks for the attention.
Thank you very much, Trine, for your presentation. We will now move over to the questions from the audience, and I would like to hand over to Luc Theo. Please, Luc.
Thank you very much, everybody. We have a lot of questions. These very interesting communications. The first question was asked, coming from Africa. African colleague lives in an area where internet is not always available. So the question is, does it exist an offline mode of those numerical platforms?
I'm not aware of any such platforms, but maybe Britta have a knowledge about that. She's more into the organization. Britta?
The platform we are using called Plejenet, as a fact, where you can take photos with your mobile phone out at the patient's home, and you can write notes on your phone or on paper. And when you come back to your station as a community nurse, you will be able to upload the photos and the notes into the system. So it can work with an offline in an offline mode. We don't use it a lot because it's a double registration for the nurses. However, it's possible.
Thank you very much. Another question: what are the costs per patient for having such a system, and who pays?
I think I will continue with that. This national agreement has been made between municipalities and regions, where we pay 50% each for the system. And the system we are using right now costs us 12 million kroner a year. We are about to make having a new tender for a new system, because we have to follow the times to get a new system that can do more things, like Klaus and Trine have shown you. And we can see that the prices for a new system will be lower than what we are now paying for the old system. I don't know how much it is per patient, because I have not made any figures on that.
And do you plan to have a cost efficacy system comparing what costs the wound now and what will cost the wound we're using telemedicine?
No, we are not planning to make a cost-benefit analysis. We made one in the beginning of when we implemented this telemedical solution, and it was very difficult to make a cost-benefit analysis that were trustworthy. And this is due to, we have a lot of, some of the costs are working hours for physicians and nurses, both in the municipalities and at the hospitals. And for example, as we can see that the wounds in the municipality I told you about is healing faster, and they have used less dressings and bandages, then it's a lower cost. But that was not put into the cost-benefit analysis, and it was very, very difficult to get data that we could use to make a trustworthy cost-benefit analysis.
Thank you very much. We have another question. Did you develop the system yourself, or is it a system you've bought?
The system we are using today is a system we have bought, and we have just launched a tender, so we will buy a new system. And Trine, you have made an app yourself, I think, in your research project.
Yeah, that's correct. That was the companies being partners in the project who have developed this app. Yeah, so it's research money who has funded that.
Thank you. Again, the same African colleague asking the question, is there a possibility to extend the study to Central Africa, or if not, how can we put in place similar studies in our context?
So is this regarding the app, or is it the...
Well, the question concerns the study. So certainly the app, yes.
Okay, it could be possible. Right now we are applying for having more money so we can have it translated. So it can also be used, for instance, in England and other countries. So why not trying to use it in South Africa? But we need research money to test it in other countries.
One of my questions is for Klaus. If you have to choose between a visio, and an exchange of pictures, what do you think more accurate and more appropriate for a complex wound?
For a complex wound, I would like to see them the first time, or at least in the beginning, and make the assessments that are needed. And then I would like to have, I would be confident to have it in the municipality with pictures and with the nurses out there. So for the complex wounds, we need to have the assessment in the multidisciplinary team first.
Excellent. And
can I add just a bit, Luc, that during Corona, we have seen some of the physicians using the videos where there were some complex situation they could not tackle via photos, but it's more cost effective to use photos, because you don't need to have a synchron in time when you meet people, so you can look at the pictures asynchronously.
And
wrong word.
Don't you miss an undermining or a cavity or something which is under the surface and you cannot see with a photo?
Yeah, I think that's actually the reason why we like to have the nurses out there, and that they are skilled in what they do, because then they could do examinations and they know they have to look for how deep the ulcer are. They probe it, and they also look for undermining.
Yeah, and that's also why we have this structured way of documenting the notes of what they see in the ulcers.
Perfect. Sebastian, we are finished.
Thank you very much for taking part of this webinar. Don't forget, you will be able to access the video recording of the webinar on demand via the EWMA website within a few days. We hope that you will join us for one of the next EWMA webinars. The next webinar is a joint ESAC EWMA webinar, which will be held on March 22nd and will focus on the impact of COVID-19 on chronic wound management and antimicrobial stewardship. You can keep yourself posted about future EWMA webinars by the EWMA newsletter, our social media, or our website. Thank you again, stay safe, and have a good evening. Bye-bye.